I want you to pause for a moment and listen very carefully. Because what I'm about to share may be the most important health message you hear this year right now. There is a medication sitting quietly in millions of medicine cabinets. It's prescribed every single day. Doctors consider it routine. Seniors take it without a second thought. And yet, over time, this medication can silently push an aging heart toward failure, without pain, without warning, and without obvious symptoms until the damage is already done. I'm Dr. Christina Serrati. For years, I've studied how the aging heart responds to long-term medications. And one truth keeps surfacing again and again: what appears safe on paper can become dangerous inside an older body. The senior heart is not the same heart you had at 40 or even 55. With age, the heart loses reserve. It still works beautifully, but it no longer has extra capacity to absorb stress. That means even a small, ongoing strain can gradually overwhelm it. And certain common prescriptions create exactly that kind of strain. What makes this so frightening is how quietly it happens. There's no sharp pain, no sudden collapse at first. Instead, the heart works a little harder each day. Blood pressure inches upward. Fluid begins to accumulate. The muscle thickens, stretches, or weakens depending on the stress. And all of this unfolds while a person believes they're doing the right thing by taking their medication exactly as prescribed. I've seen countless seniors blame early warning signs on getting older. Mild breathlessness, needing extra pillows at night, swelling around the ankles, fatigue that didn't used to be there. These are not normal signs of aging. They are early signs of cardiac overload, and here's the heartbreaking part: most patients are never warned. Doctors often prescribe medications based on studies done in younger adults. These studies may last only weeks or months. Seniors, especially those over 70, are frequently underrepresented or excluded altogether. Yet once the drug is approved, it's handed out broadly. Sometimes for years or even decades. That's how a medication meant to relieve pain, control pressure, or calm acid reflux ends up slowly injuring the heart muscle instead, not because it's evil, not because it's toxic in the short term, but because time plus age plus cardiac stress is a dangerous combination. I end this video series. I'm going to walk you through medications that place silent strain on senior hearts, explain exactly how the damage occurs, and, most importantly, show you how to protect yourself without panic or fear. I won't rush this. And I won't oversimplify it, because understanding comes before safety. Before we talk about specific medications, you need to understand why seniors are uniquely vulnerable, and why symptoms often appear only when the heart is already struggling. That's what we'll uncover next. Understand why certain medications quietly damage senior hearts. You first need to understand something most doctors never explain clearly: the aging heart operates without a safety buffer. When you're younger, your heart has reserve capacity. That means it can respond to stress, exercise, illness, temporary blood pressure changes, by working harder without injury. Think of it like a car engine that's capable of far more power than you normally use, but aging changes that. By the time most people reach their late 60s or early 70s, the heart is already operating close to its maximum sustainable workload just to meet daily demands. Walking, climbing stairs, digesting meals, even sleeping, all of it requires effort from a heart that no longer has extra margin. Now here's where medications enter the picture. Many commonly prescribed drugs subtly increase cardiac workload. Some cause the body to retain fluid. Others tighten blood vessels slightly. Some interfere with how heart muscle cells contract or how electrical signals travel through the heart. None of these effects feel dramatic in the moment. But when they occur every single day, the heart begins to struggle. This is not sudden damage. It is cumulative. A senior may feel fine for months or even years. During that time, the heart adapts by stretching, thickening, or speeding up. But adaptation is not protection, it's compensation. And compensation always has a limit. Once that limit is reached, the heart begins to fail. What makes this especially dangerous is that early heart failure doesn't feel like heart disease. There is no chest pain, no dramatic warning sign. Instead, the symptoms are subtle and easy to dismiss. Feeling winded after activities that used to feel easy. Needing extra pillows to breathe comfortably at night. Mild swelling in the legs or feet. Persistent fatigue that rest doesn't fix. Most seniors chalk these up to aging. And unfortunately, many doctors do too. By the time clear heart failure is diagnosed, structural changes have already occurred. The heart muscle may be weakened, stretched, or scarred. At that point, the damage is often permanent. This is why the phrase, "I've been on this medication for years with no problem," can be misleading. The absence of symptoms does not mean the absence of harm. Another critical issue is monitoring, or rather, the lack of it. Many medications known to affect the heart require periodic checks, blood pressure trends, kidney function, electrolyte levels, or heart imaging. Yet once a prescription becomes routine, follow-up often stops. Refills continue. The medication becomes background noise, and the heart pays the price quietly. I want to be very clear here, this is not about fear or blame. Medications save lives. Many are necessary. But in seniors, every medication must be reevaluated through the lens of cardiac reserve. The same drug that is harmless at 50 can be dangerous at 75. Next, I'm going to share the story of a patient whose heart slowly failed, not from disease, not from genetics, but from a medication prescribed for everyday pain. His experience explains why this issue deserves your full attention. I want to tell you about a patient I'll call Robert. Robert was in his early 70s. He had done most things right in life. He never smoked, rarely drank, stayed active well into retirement. His heart had never been a concern. No history of heart disease. No prior hospitalizations. By all medical standards, he was aging well, but Robert had arthritis. It started in his knees and slowly worsened over time. Morning stiffness turned into daily discomfort. Walking became painful. Getting up from a chair required effort. Like so many seniors, he didn't want to complain, he just wanted relief so he could stay active. His doctor prescribed a common pain medication. One that millions of seniors take. One that's often described as safe when used as directed. Robert was told it would help reduce inflammation and improve mobility. He trusted the advice. He took the medication exactly as prescribed, twice a day, and at first, it worked. The pain eased. Robert moved more freely. He resumed gardening. He took walks again. His quality of life improved, and there were no immediate side effects. That's what made this situation so dangerous, because while Robert felt better, his heart was being placed under constant, invisible stress. Certain pain medications cause the body to retain sodium and water. That extra fluid increases blood volume, which forces the heart to pump harder with every beat. These medications also narrow blood vessels slightly, increasing resistance. For a younger heart, this might not matter much. For an aging heart with limited reserve, it's a different story. Day after day, Robert's heart worked harder than it should have. At first, it compensated. The muscle thickened slightly to handle the load. Blood pressure crept upward. The kidneys began holding on to fluid. None of this caused pain. None of it set off alarms. After about 2 years, Robert noticed subtle changes. He tired more easily. Walking uphill left him short of breath. He began waking up at night feeling uncomfortable lying flat. He added an extra pillow, then another. His ankles sometimes looked puffy in the evenings. He assumed it was AGE. No one checked his heart function. No one questioned the medication. Refills continued. By the time Robert collapsed at home one morning, his heart was already failing. In the hospital, imaging revealed a weakened, enlarged heart struggling to pump effectively. Years of strain had stretched the muscle beyond recovery. When the cardiologist reviewed his medications, the connection became clear. The pain medication had slowly overloaded his heart, and here's the part that's hardest to accept: Robert had options. There were safer alternatives for pain management. Non-drug approaches. Topical treatments. Adjusted activity strategies. But none of those were discussed. The simplest prescription became the most damaging one. Today, Robert lives with chronic heart failure. He takes multiple heart medications. His activity is limited. And he often says the same thing: if I had known the risk, I would have lived with the pain. This is not an isolated case. It's happening quietly, repeatedly, to seniors who trust that relief today won't steal health tomorrow. Next, I'm going to explain why blood pressure medications, despite their benefits, can sometimes damage the heart muscle itself, especially in older adults. High blood pressure is one of the most common diagnoses in older adults, and controlling it is important. There's no question about that. But what most seniors are never told is that not all blood pressure medications protect the heart in the same way. Some lower the numbers on a cuff while quietly weakening the heart muscle itself. Want to explain how that happens? The heart is a muscle, powered by electrical signals and microscopic chemical movements inside each cell. Calcium plays a critical role in this process. Every heartbeat depends on calcium entering heart muscle cells, triggering contraction, and then exiting so the muscle can relax. Certain blood pressure medications work by blocking calcium channels in blood vessels. This causes relaxation, which lowers pressure. But in the heart muscle, the same blockade can reduce the strength of each contraction. In younger patients, this reduction is often tolerated. The heart compensates. But in seniors, especially with long-term use, the effect can be very different. I once worked with a woman in her late 60s who had mildly elevated blood pressure. Her numbers weren't extreme. Lifestyle changes alone might have helped. But medication was started quickly. And she took it faithfully for years. Her blood pressure looked excellent on paper. What no one checked was her heart's pumping strength. Over time, the heart muscle became weaker. Each contraction moved less blood forward. The heart stretched to compensate, becoming thinner and less efficient. This process, called dilated cardiomyopathy, develops slowly and silently. There's no pain involved. No obvious warning. Fatigue becomes constant. Walking short distances feels exhausting. Dizziness appears. Eventually, the heart can no longer keep up with the body's needs. By the time imaging is done, large sections of the heart muscle may already be impaired. And unlike skin or muscle in your arms, heart muscle does not regenerate. Once it's replaced by scar tissue, that loss is permanent. This is why monitoring matters. Certain medications require periodic evaluation of heart function, especially in older adults. But in real life, once blood pressure numbers improve, attention often shifts elsewhere. Refills continue. The heart is assumed to be fine. It's also why symptoms are misinterpreted. Seniors are told they're tired because they're aging. Shortness of breath is blamed on fitness level. Lightheadedness is dismissed as dehydration. Meanwhile, the heart muscle weakens. I want to be very clear, this does not mean blood pressure medications are bad. Many are life-saving. But selection matters. Dose matters. Monitoring matters. Lowering blood pressure at the cost of heart strength is not a victory. In the next part, I'm going to explain how a medication many seniors take for stomach issues, often for years, can destabilize the heart's electrical system and trigger dangerous rhythm problems. This one surprises almost everyone. Heart damage doesn't always begin with weakness. Sometimes, it begins with rhythm. The heart is not just a pump, it's an electrical organ. Every beat depends on precise signals traveling through specialized pathways. When those signals become unstable, the heart can fall into dangerous rhythms that increase the risk of stroke, heart failure, and sudden collapse. And surprisingly, one of the most common triggers in seniors comes from a medication prescribed for the stomach acid reflux and heartburn affect millions of older adults. To manage this discomfort, doctors frequently prescribe strong acid-suppressing medications. They work quickly. They relieve symptoms. And because they're effective, they're often continued for years. What's rarely explained is what happens behind the scenes. Stomach acid isn't just for digestion. It plays a crucial role in absorbing essential minerals, especially magnesium. Magnesium is vital for the heart's electrical stability. Without enough of it, electrical signals become chaotic. When acid production is suppressed long-term, magnesium absorption drops. Blood levels slowly decline. This doesn't happen overnight. It happens silently, over months and years. Most seniors feel nothing at first, but as magnesium levels fall, the heart becomes electrically irritable. Skipped beats appear. Palpitations begin. Eventually, the heart may slip into atrial fibrillation, a rapid, irregular rhythm that allows blood to pool and clot inside the heart. I've seen patients shocked to learn that their heart rhythm disorder didn't come from heart disease at all. It came from a medication they took every morning to prevent heartburn. Once atrial fibrillation starts, it often doesn't stop. Even if magnesium levels are corrected, the heart's electrical pathways may already be altered. Long-term medication becomes necessary. Blood thinners are prescribed. Stroke risk rises permanently, and here's what makes this especially tragic: these medications were originally designed for short-term use, often just a few weeks. Yet many seniors remain on them for a decade or longer without reassessment or monitoring. No blood tests. No warnings. No conversation. Meanwhile, magnesium levels quietly drop. This isn't rare. It's common, and it's preventable. Dietary changes, milder medications, or intermittent use often provide relief without disrupting mineral balance. When stronger medications are necessary, monitoring magnesium is critical, but that step is frequently skipped. By the time symptoms appear, the heart's rhythm may already be compromised. So far, we've talked about medications that strain the heart, weaken the heart muscle, and destabilize the heart's electrical system. Different drugs, different mechanisms, same outcome: cardiac damage that could have been avoided with awareness and oversight. Next, I'm going to explain why diabetes medications can trigger fluid overload and heart failure in seniors. Even when blood sugar looks well controlled, diabetes management becomes more complex with age. Blood sugar control is important, but in seniors, how that control is achieved matters just as much as the numbers themselves. Some diabetes medications lower blood sugar effectively while quietly increasing the risk of heart failure. The mechanism is subtle, which is why it's often overlooked. Certain diabetes drugs work by making the body more sensitive to insulin. On the surface, this sounds beneficial. Blood sugar improves. Lab results look better. Doctors feel reassured, but these medications also cause the kidneys to retain sodium and water. That fluid doesn't stay harmlessly in the bloodstream. It increases total blood volume, raising pressure inside the circulatory system. For an aging heart already operating near its limit, this added workload can be devastating. At first, the heart adapts, the chambers stretch. The muscle works harder. The patient may notice mild swelling in the legs or unexplained weight gain, but it's rarely connected to the medication. Over time, the heart's pumping ability weakens, shortness of breath develops. Lying flat becomes uncomfortable. Fatigue becomes constant. These are classic signs of heart failure, but in seniors with diabetes, they're often misattributed to age or inactivity. What makes this particularly dangerous is that many seniors already have subtle heart changes before starting diabetes treatment. The medication doesn't create the problem, it accelerates it, and because blood sugar improves, no one suspects harm. I've seen patients told, "Your diabetes is under excellent control," while their hearts were quietly deteriorating. There are safer alternatives. Modern diabetes medications exist that not only control blood sugar but actually protect the heart. Some reduce fluid overload instead of worsening it. Some lower cardiovascular risk rather than raising it, yet older drugs remain in use because they're familiar, inexpensive, and effective on paper. This is a pattern you're probably starting to recognize. Numbers improve. Symptoms are ignored. Long-term consequences appear years later, and by then, the heart has already paid the price. Heart failure in seniors is not always the result of blocked arteries or heart attacks. Very often, it's the cumulative effect of medications that added just a little too much strain for just a little too long. In the next part, we'll talk about medications prescribed for mood, sleep, and nerve pain, and how they can interfere with the heart's electrical timing, increasing the risk of dangerous rhythm disturbances. This is another category that surprises many people. As we age, it's common to be prescribed medications for sleep, mood, or chronic nerve pain. These drugs can be helpful, especially when discomfort or insomnia interferes with daily life. But some of the older medications in this category carry significant and often overlooked cardiac risks. Particularly for seniors, the danger lies in how these drugs affect the heart's electrical timing. Every heartbeat follows a precise sequence of electrical signals. If that timing is disrupted, the heart can fall into dangerous rhythms, some of which can be life-threatening. Certain medications used for depression, nerve pain, and sleep work by altering nerve signaling throughout the body. Unfortunately, the heart is not exempt from these effects. These drugs can prolong the heart's electrical recovery phase, a phenomenon known as QT prolongation. When this happens, the heart becomes vulnerable to sudden, chaotic rhythms. In younger adults, the risk may be small. But in seniors, especially those taking multiple medications or with existing heart changes, the risk rises sharply. What makes this particularly concerning is that symptoms often don't appear until a serious event occurs. A senior may feel fine, then suddenly experience dizziness, fainting, or collapse without warning. In some cases, the first symptom is cardiac arrest. I've seen patients who were prescribed these medications years earlier without ever being told their heart rhythm needed monitoring. No EKGs, no medication reviews, just automatic refills, and the risk compounds. Electrolyte imbalances, kidney changes, and other medications can amplify the electrical effects. A drug that seemed harmless at first becomes dangerous over time as the body changes. This is why medication lists must be reviewed regularly, especially when new symptoms appear. Sleepiness, lightheadedness, or palpitations are often brushed off. But they may be early signs of electrical instability. Safer alternatives often exist. Newer medications for mood and nerve pain tend to have a much better cardiac safety profile. Non-drug approaches, dose adjustments, or targeted therapies may reduce risk without sacrificing relief. The problem isn't treatment. It's outdated treatment without reassessment. So far, we've covered pain medications, blood pressure drugs, stomach acid suppressors, diabetes medications, and mood-related prescriptions. All different. All capable of harming the heart when used improperly or without monitoring in seniors. Next, I'm going to explain something deeply ironic and deeply concerning. A medication designed to treat heart rhythm problems can actually worsen heart failure in older adults. There is something deeply unsettling about discovering that a medication prescribed to protect the heart can, in certain seniors, do the exact opposite. Yet this happens more often than most people realize. Some rhythm control medications are designed to keep the heart beating in a normal pattern. On the surface, the goal is noble: prevent irregular rhythms, reduce symptoms, and lower stroke risk. But in older adults, especially those with underlying heart weakness, certain rhythm medications can suppress the heart's ability to pump effectively. The heart becomes slower, weaker, and less responsive. This is particularly dangerous in seniors who already have reduced cardiac reserve. The medication may control rhythm while quietly worsening heart failure. What makes this so insidious is that symptoms overlap: fatigue, shortness of breath, reduced stamina. These can be blamed on aging, heart rhythm issues, or other conditions. The medication itself is rarely suspected. I've seen patients whose heart function declined rapidly after starting a rhythm medication. Yet the decline was attributed to progressive heart disease rather than the drug. This creates a vicious cycle. The heart weakens, symptoms worsen, more medications are added. The original cause remains unrecognized. Black box warnings exist for some of these drugs. They clearly state the increased risk of heart failure in certain populations. Yet prescriptions continue, often without careful patient selection or close monitoring. Once again, the issue isn't that these medications are always wrong. The issue is context. Age matters. Existing heart function matters. Duration matters. A medication that helps one patient may harm another. This is why heart imaging, symptom tracking, and periodic reassessment are essential, especially after starting or changing heart-related medications in seniors. The saddest part is that many of these complications are preventable. Alternative strategies exist: rate control instead of rhythm control, lower-risk medications, non-drug interventions. But these options require time, discussion, and individualized care, and those are often in short supply. At this point, you might be feeling overwhelmed. That's understandable. We've covered a wide range of medications, and the picture may seem unsettling, but this knowledge is empowering, because awareness allows prevention. In the final part, I'm going to pull everything together. I'll clearly outline the medication categories you should question, the warning signs you should never ignore, and the steps you can take, starting today, to protect your heart without making changes on your own. If there is one message I want you to take away from this entire discussion, it's this: you are not powerless. Medications are not inherently good or bad. Their impact depends on age, duration, monitoring, and individual heart health. The danger arises when prescriptions continue unquestioned for years. While the body quietly changes, the good news is that heart damage from medications is often preventable when caught early. The first step is awareness. If you are over 65 and taking medications regularly, your heart deserves periodic evaluation, not just blood pressure readings or blood sugar numbers, but real oversight. That means asking informed questions and advocating for yourself. Start by reviewing your medications. Write down every prescription, every over-the-counter pill, and every supplement you take. Many cardiac effects come from interactions, not just individual drugs. Bring this list to your doctor and request a full medication review with a specific focus on heart safety. You are allowed to ask, is this medication still necessary? Are there safer alternatives for someone my age? Should my heart function or electrolytes be monitored? Could any of these drugs increase my risk of heart failure or rhythm problems? A good physician will welcome these questions. The second step is recognizing early warning signs. Do not dismiss symptoms as just aging. Shortness of breath, swelling in the legs, unexplained fatigue, dizziness, palpitations, or needing extra pillows at night are signals, your heart asking for attention. The earlier these signs are addressed, the better the outcome. Third, never stop a medication abruptly on your own. Some drugs require tapering. Others can cause rebound effects if stopped suddenly. Any changes must be made under medical supervision. Safety comes from collaboration, not fear-based decisions. Finally, remember this: comfort today should never cost you independence tomorrow. Pain relief, symptom control, and convenience matter, but not at the expense of heart health. When safer options exist, they deserve consideration. Aging does not mean surrendering quality of life. It means being more selective, more informed, and more proactive. Your heart has carried you through decades of living. It deserves protection in the years ahead. If this information helped you, share it with someone you care about. Many seniors are suffering not from disease, but from unexamined prescriptions. Knowledge saves lives.